delighted to be joined by Dr. Marianne Coleman, who's the person with the flowers behind them. Marianne is a clinical vision research fellow at the University of Melbourne, although we met when you were working at the University of Surrey, of course.
Yes, good evening from Australia.
I was going to say it's late at night there, right?
It is, but that's okay. I'm really glad to be here.
Thank you. And I'm also joined by Dr. Catherine Quinn. Fun fact for you, Catherine.
What's that?
Out of 56 researchers that are joining me today, 3 of them have the surname Quinn, and you're not even related.
It's a good surname, isn't it? You know, that's why, obviously.
It's not even I mean, 3 Smiths, 3 Joneses, I can understand. Being a Smith myself, I can say that. But 3 Quinns, that's got to be unusual, right?
It's normally the opposite problem, which is the Catherine part. There's normally too many Catherines, so
there are a lot of Catherines in Catherines and Katies. There are a lot of Catherines and Katies in dementia research.
Yeah.
And Johns. I can say that because I work with lots. Thank you. We have Dr. Catherine Quinn, before I pick on you for your surname, who is a lecturer in dementia studies at the University of Bradford, where there's lots of research going on. So maybe, Marianne, can I ask you to introduce yourself first?
Yes, so I am a slightly different kind of researcher. I am an orthoptist, but you can call me an optimist if you like. Orthoptist literally means straight eyes. So I'm a clinical professional in eye care, and we specialize in diagnosing and treating problems with moving our 2 eyes around and using them together to see 3D. So what's that got to do with dementia? So because these kinds of problems with your eyes can happen at any age, it means that we are specially trained to assess eyesight for lots of different people, including people who may struggle with communication or may have some form of memory difficulty. So that's basically part of the reason that I'm here.
Fantastic. Thank you, Marianne. Sorry, I was checking the Twitter to see if there were questions, and there were last time that I missed. Catherine, could I ask you to introduce yourself as well?
Yes, I'm Dr. Catherine Quinn. I am a lecturer in dementia studies at the Centre for Applied Dementia Studies at the University of Bradford. So I have a great job because I get to teach people about dementia and dementia studies. I've been in the dementia research field for quite a while now. Before I became a lecturer, I was a senior research fellow. So, and I guess the project I'm going to talk to you today about is around living well with dementia, which, a bit like Marianne, sort of takes a bit of a holistic approach and thinks about, you know, all the different types of factors that might have impact on how people are coping with dementia.
Brilliant. Well, actually, while we're on the topic, then we'll stick with you, Catherine, and could you tell us about your work?
So I'm going to talk to you today a little bit about the IDEAL programme. The IDEAL programme has been running since 2014. So this is a study that I've been with for longer than even doing my PhD. So 2014, so the IDEAL programme, what is it? It's a cohort study. So it's based in Great Britain, and it's a cohort study looking at living well with dementia. And when I'm saying living well with dementia, what do I mean? I'm talking about things that are linked to people's quality of life, their well-being, and their satisfaction with life. And it's a cohort study, which means we follow a group of people with dementia and their carers over time to look at factors that are linked to living well. So we take quite a holistic approach, which means we look at a range of factors, including psychological, social factors. We look at health. We have looked at eyesight. So look at a broad range of topics that could be linked to people's ability to live well. And as I say, the study's been running for a number of years, which means we've been following people up over time. Currently, at the moment, we're just reporting on what we call the cross-sectional findings, which is the baseline data. But lots and lots of findings coming out of this study. It's involved quite a large sample of people at time one. So just over 1,500 people living with dementia and just under 1,300 carers taking part at the first time point.
Oh, there we go. And my research is at the complete opposite end of the spectrum in terms of numbers, because it was a relatively uncharted piece of territory when it comes to dementia research. So mine was a pilot study, and I would have liked to have recruited more people, but in the end, I had 24 people living with Alzheimer's disease, vascular dementia, or mixed dementia who took part. And it just goes to show that you have small scale studies to find out whether a research topic is something that you want to look into in more detail before you do a big study. And then you have enormous sample size studies like Catherine's, where we knew that this was an area that needed more work from things that had been done in the past, but it was just a case of looking at this over time in a big group of people in order to be able to, you know, take that research forward, essentially.
Yeah, so actually, Catherine, can I just come back to you? So that study, is that just happening in Bradford, or is that elsewhere across the country in the UK?
No, so it's obviously the study itself is led by Professor Linda Clare down at Exeter. So originally, at the baseline, we've got 29 locations in Great Britain. So England, Scotland, and Wales. So all over, it means that we can include people from rural areas and urban areas. And I think just the rationale for having such a big cohort study is because we don't do these types of studies in the UK. And it enables us to look at many factors and sort of put them all together to look at how they link to living well. So to build that sort of evidence base. But again, taking a very holistic approach, you know, not just looking at things such as the impact of somebody's cognitive function, but looking at more broader things such as their psychological well-being, where they live, etc. So many different things we can look at.
And I've seen that I mean, that is being prioritized, isn't it? I mean, I think this is something that, you know, you're hoping to be able to offer as part of an NHS care service.
I think it really highlights the importance, and I think about Marianne's work, you know, just if you're looking at Eyesight, it sort of really highlights to me this, you've got to take this very holistic approach at looking at many different factors and how they link to a person's living well. We've very much been dominated by a kind of medical model where we've looked at things such as how somebody's cognitive function or abilities might link, but we've not thought more broadly around, for instance, comorbidities. So if somebody's got issues with eyesight or hearing or other health conditions, how this has an impact on, you know, their ability to live well, to sort of take a more broader look.
Yeah, which makes complete sense. Actually, before I come back to you, Marianne, we've got a question from Martin Cooper, who makes a good point, who asks, what's a cohort study? It comes up often. Does this term come up in academia? Do you want to explain that?
Yeah, so a cohort study is basically we follow a group of people over time. So it's a cohort. A cohort is a group of people. So, and we look at them, and as I say, we follow the same group of people over time. So we originally going to follow them up for 6 time points. It's a little bit different now with COVID, but that's the idea of having a cohort study. It's a group of people.
Yeah, and that could be it could just be a group of the general public, can't it? They don't all have to have be living with dementia, for example. This could be a common one. Is all the people born in 1963, for example?
So there's some really highly influential cohort studies. For instance, you know, in Bradford we have Born in Bradford, but they're very important because they give us a big evidence base, and because it's longitudinal, you're following people up over time.
Longitudinal mean that exactly. You have so you pick a group of people, you do some initial tests and gather some information from them, then you repeat that at a certain frequency for a long period of time, that then allows you to compare. So if in 20 years time somebody does go on to develop Alzheimer's, for example, you could have a look at all the people that developed Alzheimer's and look back over all their information over a long period of time to see if there were any common aspects, like did they eat the same food, live in the same place, breathe the same air, have the same care, for example. So
ours is obviously starting off with people who had mild dementia, but yes, there are lots of cohort studies that have started off with people when they were born. They are very expensive studies to run because they need investment, which is obviously why we need research funding, but they provide a really strong evidence base. So at the moment, we've just got funding to look at the impact of COVID-19 on our participants. And that's really helpful because we've got a lot of baseline, we've got a lot of information about them before COVID came along, so we can look at the changes that take place, you know, now that COVID's here, and how that is having an impact on our people.
Well, at least that's something to come out of the pandemic.
Well, I was just going to say that I mean, and that's something that, because of course there are these questions about what might the long-term effects be on cognition, for example. Marianne, I'm going to come to you next. So yours was a smaller study, And are you now, are you trying to upscale that? Go into more detail about your research.
Yeah, of course. So mine was also looking at change over time. So I had my 24 volunteers who had all been diagnosed with one of those types of dementia that I mentioned within the past 2 years. So they were all fairly recently diagnosed, which ties in with some of the stuff that Jane and Chris were talking about during the opening segment of this chatathon. And I saw them for the first time, did a bunch of eye tests with them. They were all really non-invasive, really simple tests. They were adapted to accommodate the different levels of dementia that people might have. And we repeated those eyesight tests and a memory test once every 4 months. So I saw them 3 times in total. So it was an 8-month period that we were monitoring them, which it might seem like quite a short period of time. You think, oh, well, what can you say in 8 months of monitoring? But actually, because it was what we call a pilot study, because people hadn't done research in this area before, this study is the first one to look at changes in eyesight specifically over time and looking at people's ability to judge distances, for example. It was better to do a shorter study to look at whether there was a change at all, to determine whether monitoring long term might be more beneficial. So the research essentially was looking at these changes over time for in eyesight, inability to judge distances, which is important to help us with how we walk, and also how we look at people's ability to do fiddly hand-eye tasks, their confidence in mobilizing to be able to locate obstacles and determine changes in height of, how low down is that step, how high up is that curb, all of that sort of thing. So my research followed people for that 8-month period, looked at changes in their eyesight and their ability to judge distances. And actually, one of the key things to come out of that was that difficulty with seeing well should not just be put down to, oh, it's because they have dementia. So selecting the right eye tests and having a dementia-friendly testing approach is really crucial to confirm whether somebody has a visual problem. And by this, I mean being able to adapt your approach to the individual based on their level of dementia and what they find difficult, and choosing a test to accommodate that. Because we have lots of different ways to test eyesight that don't just rely on, oh, can you read this letter chart? Which thing is better, 1 or 2? We have lots of different ways to assess eyesight that don't just rely on the letter chart or the person being able to communicate. And so with those right tests and techniques, people living with dementia can participate in their eye test as much as possible. And actually, many of the people who took part in the research demonstrated a good level of eyesight, particularly in the distance. And changes that they experienced in their eyesight were mainly due to the presence or the progression of other age-related eye diseases. So things like cataract, which is where the lens inside the eye goes cloudy and it needs to be extracted in surgery, or high pressure inside the eye can also cause changes in your eyesight as well. So basically, poor eyesight is not necessarily because somebody has dementia. It can be because they don't have quite the right glasses. They might have some kind of age-related eye disease. They might not have as good lighting in their home. And I think there's a few things focusing on that later on, about the sort of environmental conditions and so on. And all these things can be just as important for living well with dementia, to ensure that people do have good eyesight, as best eyesight as they can enjoy as possible. My research did find that people living with dementia have difficulty judging distances. Okay, so we did know a little bit about that before the research was done, but with the testing and everything that we did here, we can be quite confident that the people who took part did have that difficulty. And so, because if you have trouble judging distances, it can increase your risk of falling. And obviously falling is not good, regardless of whether or not you have dementia. But for people with dementia in particular, having a fall can be really adverse, because if you have a hospital admission, that can then lead to other things that can cause later deterioration in your memory test scores and so on. So basically, the study emphasizes the importance of maximizing the level of vision in both eyes to ensure that you can use your eyes together as a pair as best you can. And that this should be something that is considered in every eye test that somebody living with dementia receives. And indeed that perhaps people living with dementia should have an eye test routinely, as you know, once they have their diagnosis. So those were the main findings essentially.
We've got a few questions in it, and Fiona confused us slightly there. Fiona, you arrived 15 minutes early, but thank you very much. Just popping in. Oh, and Leo's joining too. I just need to remind guests again that they should join at the time they're allocated, not early. I'm going to pick up on the questions. We've got a question from Jill Keithley, who asks, what's the definition of living well with dementia if you're judging how well somebody is living well with dementia? Do you have a definition of that, Catherine?
You know what? It's a so as a study, very specifically as a study, as a research study, we had to pick certain outcome measures. So these are ways quantifying how you measure it. So we measured it looking at well-being, life satisfaction, and quality of life. And these are very sort of measures about how people are getting on. So we as a study do that. However, I will also say that I have done some work which asks people with dementia, what does living well mean to you? To ask them themselves. And you get a lot of information. So a lot of people talk about having an engaged and active lifestyle. People talk about positive relationships with others, good living situation and environment. So there's what I'm trying to get across is there's obviously the way in which we as researchers sort of define it to measure it, but obviously that it's very personalized to that individual. What counts as living well to one person may mean something different to a different person. So individually, it's quite personalized into what, ultimately what people think are important to them.
That is tricky, isn't it? Am I a little bit noisier now? Is that better?
Yeah.
Oh, good.
That volume's good.
It is. That is exactly. It's kind of, I guess, you've also got to compare, I think, to what life was like before and after, because not everybody lives particularly well before their diagnosis. And I think you've got to compare to say that there is this stand. I think you could maybe set some standards to say everybody should have a certain level of life satisfaction, but not everybody is healthy and things before their diagnosis. It is a tricky one. Erin Partridge asks, you, Marianne, they're interested to hear what Dr. Coleman is able to bring. Interested to hear how Dr. Coleman is able to bring people along to understand why we need to understand eyesight changes for people living with dementia, fighting that perception out there that we've all heard, which is, why bother? You've got dementia anyway. It doesn't matter if they can see or not or can hear. How do you fight that perception?
Yes, it is a bit of a struggle, especially in arenas outside of dementia care. So, for example, there is a movement towards encouraging people living with dementia who have cataract to have their cataract extracted earlier than you otherwise would do. So cataract is an age-related condition where the lens inside the eye becomes cloudy over time and it becomes really difficult to see through. As soon as you extract the cloudy lens and replace it with a new plastic one, you can see a lot better. But for the operation is normally done under a local anaesthetic with the patient awake during the procedure. So for people with more advanced dementia, it's much harder for them to cooperate during the procedure, which requires you to be very, very still. So I have encountered attitudes amongst ophthalmologists around the idea of just operating on the one eye. But if you have a blurry eye and a clear eye, then it's much harder to use your eyes together as a pair, which can throw off your ability to judge distances. So yeah, effectively, yeah. It can be really disorienting if you can't rely on the input from each eye. And so that can increase your risk of falling as well. So effectively, yes, it is a battle. It is a battle to change people's attitudes with regards to that, and to just be like, to try and stop people from saying, oh, your eyesight's not very good, but it's probably just your dementia. It's like, well, there's no reason why people living with dementia can't enjoy a good level of eyesight as long as a lot of these conditions are treated. I'm talking purely here in terms of how many letters you can read on an eye chart. Okay, so there are people living with dementia, and I can see a few questions related to this, who experience problems with their visual perception. And that is a completely separate issue.
FTD. We've got a 45-minute session after lunch today talking specifically about FTD as well. So Caroline, you might be interested in that session particularly. Should we take that question from Erin, Marianne, which is what's the difference between a, because I guess picking up the point before, another way to do this is to, of course, do eye tests in people's own homes and not have to, part of the stress and agitation can be caused by having to go into town or go to an eye test and then sit in that darkened room, which we know can be quite disorientating. There are other ways. So how do you do a dementia-friendly eye test?
I'm glad that you asked. So I'm hoping that the lovely people at the Dementia Australia Research Foundation will fund some further work in this area. I've just submitted an application to them, which hopes to consult with people living with dementia, with carers, and with people who do eye tests, who are called optometrists, about what should be in a dementia-friendly eye test. So my own experience of working with people living with dementia, they will respond very well to testing if you are demonstrating to them what is required. And also to listen carefully to what they're saying, because it can be difficult for them to put into their own words what it is that they're seeing, in order to use your own clinical knowledge as an eye care professional to understand what it is that they might be seeing, and to adjust your communication to help them to tell you that. So we have lots of different ways of testing people's eyesight, as I mentioned before. And some of them rely on the person being able to tell you what they see, and other ones don't. Now, when you go and have your eye test done, you normally are asked to look at an eye chart, read an eye chart, and then look through a bunch of lenses and say, which is better, 1 or 2? Is this better? Is this worse? Etc. etc. But we have ways of assessing eyesight that don't require these things. So we can just look at how people's eyes move around to look to see whether they see something or whether they don't. The other thing that's important to consider as well is that sometimes when you're asking somebody to name a letter, they might not always name the letter that they see. So they might be looking at the letter and they can see the letter and they know it's a letter, but then when they try to say, oh, it's an O, it comes out as a 0 instead. And that was something that was quite common, that people substituting numbers for letters and things like that. And so these kind of considerations are important during testing.
Thank you. I mean, obviously, I don't want to ignore your question, Caroline, about FTD being frightened of heights and drops. But I think if you come back, and I will save your question for the FTD group of researchers from UCL. There are 5 of them joining us, I think, at 1:45 today. So if you'd like to join back then, I will put that question to them.
And UCL also have some fantastic researchers that are looking at eyesight for people with posterior cortical atrophy as well. So perhaps they might be able to speak to that.
We got just one last quick question before I come back to you for final points. Terry Blatter asked, does Marianne have a strategy for the situation where visual acuity is relatively okay, but the condition of the diagnosis of Lewy bodies creates visual difficulties so that the reading is impossible and vision is generally problematic and the person can't understand? What do you do, Marianne? Do you stick a pair of glasses on somebody and say, is that better or worse? And I mean, if they can't even communicate, how do you deal with this in the worst of situations?
Okay, that's a really good question. Thank you, Terry. It is difficult, partly because we don't actually have a dedicated eye care pathway for people living with dementia. There's still an awful lot of research to be done in this area. Unfortunately, it's still very early days for this aspect of living with dementia, looking at eyesight and problems with visual processing. So in some kinds of dementia, you can, and in particular with Lewy body dementia, you can experience visual hallucinations. Those can be a really difficult problem for people with those diagnoses to live with. And in addition to that, again, we still don't know as much as we ought to about how the brain and the eyes work together and how this is affected in dementia. So it tends to be more of a holistic approach to the reading difficulties. Ideally, people living with dementia should be able to access certification for blind or partially sighted status, which can be done by an ophthalmologist if they have so much trouble with reading and so on, despite having normal vision. So say, for instance, they might have a visual processing deficit, then having that certification can help that person to access the kinds of services that are normally available for people with poor eyesight. So they can access talking books, they can access large print newspapers and books, and other kinds of more functional support with mobility and things like that. So obviously the person's ability to use these kinds of aids can be more limited, but there are numerous radios and audio recordings, audio devices rather, for people who have poor eyesight, which in turn, a lot of the button arrangements and everything are also quite conveniently designed for people living with dementia as well. So there's that to consider as well. But yeah, it is an issue. But now on the blind and partially sighted certification form, there is a box that you can tick to say that somebody has dementia, and that's a good development in the UK recently.
You can see how doing tests around somebody's own home, like can you reach and grab this or touch this, or can you see this in somebody's own home, might be a way to do that. Catherine,
yeah, you can adopt a more functional approach to assessing eyesight. Yeah.
Catherine, before we wrap up, I just want to ask what's coming up for you in the next 6 months over your research. How are you? What's the focus for the next period?
So the focus for the next period with IDEAL is that we have what's called the Include study running. So basically, we are now looking at the impact of COVID-19 on IDEAL participants. We've already started doing some interviews, some very interesting findings coming out of that. These are interviews with people with dementia and carers, in terms of the impact on carer stress. So really, that is the focus of work.
To try and adapt the outputs to yeah. Fantastic. Honestly, again, I'm really sorry we didn't get longer to talk, but we've come up to our 10:30 already. Thank you very much, Dr. Marianne Coleman, Dr. Catherine Quinn. Both, I should add, as I'm going to do, all of our guests' information on their social media, their Twitters is on the website on chatathon.uk. And Meet the Researchers, I think it's called, is the section where there you can find details on all the people who are speaking today. If you had a question that you didn't manage to get answered, or you have any follow-up, please do go and reach out to them via Twitter. I know they're all very friendly people and will happily reply to you on there. And you can also find out more information about their work there too. So please do meet them. Thank you very much again, Marianne and Catherine, and I'll see you again soon.